Hey, OncoPTs, I have a special treat for you today because not only is this woman absolutely one of my favorite OncoPTs there is, she's also the OncoPelvic PT on all the social medias. She has inspired me in my own social media content creation journey, and she is continuing to challenge me to be a better physical therapist every single day that I watch her. And I'm so excited to have her back on the OncoPT podcast. My amazing friend, Dr. Alexandra Hill. Welcome back.
Thank you so much. And I have to say, you always inspire me as well, just to do better and to reach more people and to just have a bigger impact in oncology PT. So thank you for all that you do and for having me on the show again.
Oh my God. I couldn't wait to have you back. Our last interview was a riot because we covered some really amazing stuff.
Was that the corn one?
You know, now that you say that, I don't even know. I forgot all about
that. That was one of the most excellent conversations I've had on a podcast before.
It's funny you bring that up because I had a conversation with my mom like a couple months ago, and I told her, I said, yeah, my friend Alex is, an oncology pelvic floor physical therapist. And she was telling me, because we were talking about constipation, this, that, and the other, because she's in oncology, I'm in oncology. And I was like, yeah. And like, there's the corn test. Have you heard about the corn test? And she was like, no. And I was like, it's this amazing thing Alex told me about. Okay, Alex, first question of the interview. What is the corn test?
So it's essentially a very cheap, easy way to actually see what your colonic transit time is, meaning when you eat something, how long does it take to actually evacuate it? So as most people know, when you eat a lot of corn, it doesn't all get digested. So then when you have a bowel movement, then you see the corn there and you say, oh, hey, corn. So this test, you eat a whole bunch of corn and then you track to see when you actually evacuate it. So you can see, okay, is this taking a really long time for my bowels to evacuate, or is this really quick? So it's good kind of easy starting point to see how your gut motility is.
Every once in a while I think of the corn test and I just dissolve into giggles. Because I'm secretly like a child. I am a child.
This is why I love my job so much.
We talk about poop all the time. Absolutely.
Right?
This, as it does, it ties in really well to why I have you here on the podcast today. So for the listener who's like, oh my God, we're talking about corn and poop within the first 30 seconds of our interview. Yes, we are. Alex, can you tell us who you are now that we got the corn test out of the way?
Absolutely. So I'm Alex. I'm an outpatient physical therapist. I currently practice in Jacksonville, Florida, and I specialize in pelvic health and oncology, and I treat all genders. And I also do lymphedema, and I've been practicing for 9 years. It's weird that it's been 9 years. But I've been doing this ever since I graduated. I went to school at UF, so go Gators, anybody that's out there that's a Gator. And then I did my residency in women's health at Duke. And then, like I said, since then I've been doing this ever since, talking about poop and corn and pee and sex and all the things down below.
We were talking off air before the interview began. And one of the things that we both were like, eyes lit up, like, oh my God, yes, this is a problem, is despite the tremendous crossover that there is within oncology and pelvic floor physical therapy, I think there is still so much distinction between these two specialty areas, when in fact there is so much duality, may not even be the word, but in my oncology patient population, I see so much pelvic floor dysfunction, and I'm not even treating patients for pelvic floor issues, right? Like when they come and see me, most of my patients right now are breast cancer survivors, underwent, usually chemotherapy, radiation, surgery, a lot of times some kind of breast reconstruction. And I think I shared this with you previously when I had you on the podcast. I did an informal poll of my patients.
Yep.
In my private practice. And to my surprise, 50% of them have been chronically constipated even before their cancer diagnosis. To the audience listening right now, this is just to show you how prevalent this is, and you probably don't even know it. So, Alex, why is this so common? Why is there so much pelvic floor oncology overlap in our world?
Yeah, absolutely. So, and I think we first need to back it up to just pelvic health itself and how
Yeah.
prevalent it is. 1 in 3 women and people assigned female at birth are going to have a type of pelvic floor issue. I think
Mm-hmm.
it's like 1 in 7 or 1 in 8 men are people assigned male at birth. I mean, that
Yeah.
is such a high
It's
number,
huge.
and medical providers aren't talking about it. They
Mm-hmm.
don't know what to screen. They don't know what to ask. They don't feel comfortable asking. The patient sure as hell doesn't want to ask or bring up something if
Mm-hmm.
their doctor's not going to bring it up. And so it's not even being talked about. So then you add on the layer of a cancer diagnosis. And I hear this all the time from the people that I work with, is basically like, well, I beat cancer. I'm alive. I shouldn't feel like I should be able to enjoy sex. I shouldn't be worried that I'm peeing my pants. Like, people trivialize it and minimize it so much because they feel like they have to be so grateful to be alive, but you should be able to thrive now. And so it's just not
Mm-hmm.
talked about, even though, like you said in your informal poll, so many people are experiencing it. The majority of people that I see for oncology or lymphedema, of course, I always screen them for pelvic health
Mm-hmm.
issues. I would do that even if I wasn't a pelvic therapist. But um, I can't tell you how many people tell me, yes, they do have an issue. Yes, they do want to work on it. No, they didn't talk about it with their doctor. Yes, they would like me to ask for a referral. And then I see them once we're done treating the oncology dependent symptoms like lymphedema
Mm-hmm.
or range of motion.
Mm-hmm.
And so I think, there is a huge overlap just with what people experience anyway with their pelvic health. But then all of the side effects of cancer treatment are then going to compound those and potentially make those even worse or exacerbate them.
Mm-hmm. And I think, one of the things that, because you've really got me plugged into like pelvic health, one
Yes.
of the things that I'm seeing, oh my God, like total inspiration, like you're the whole reason why we're having this conversation, obviously, is how underserved the pelvic health is in general, especially in this country. But there's so much conversation, I feel like, that I'm just now seeing. It's been happening, I just haven't been seeing it previously, about the fourth trimester, and then even like what happens after the fourth trimester of, we have these patients who have given birth, who have delivered a pregnancy, who have been pregnant and are having all of these issues, and it's just expected that you're gonna get over them, like your body,
You deal with
you'll
it.
bounce back or whatever.
Yeah.
And they don't, because that's not how the human body works, because you literally just underwent major trauma. Like, my
Right.
God.
Exactly.
And then fast forward, and these patients experience a cancer diagnosis, and so
Hmm.
now we have these already pre-existing issues that we are now compounding
Yep.
cancer and cancer treatment on top of,
Yep.
right?
Exactly. Exactly. And then it's still not getting addressed. It's still not getting addressed. And that's, one of the whole reasons why I started my side business of OncoPelvic PT,
Mm-hmm.
is to increase awareness, increase education. Initially, it was
Mm-hmm.
more kind of patient facing,
Mm-hmm.
but now it's evolved to be also clinician facing, because we just have this gap in not having enough providers that know what to do. Or, I'm right now booked out a couple weeks from my first appointment. I know other therapists, pelvic health therapists, that are booked out
Yeah.
months in advance.
Yeah.
And we as oncology PTs should be able to address at least some of those more simple issues coming in, to at least get them started. We
Mm-hmm.
educate people on nutrition already, right? We educate people on sleep and sleep hygiene,
Mm-hmm.
right? Those are two really important things in pelvic health. So why aren't we all, beyond just oncology PT, but why aren't we
Right.
all talking about it? And like you said, it's
Yeah.
like almost a disconnect. And I feel like some people may see it as like almost like a territory thing, like I'm a pelvic PT, only I can do this, or I'm a oncology PT or OT, like only I can do that, and it's like, but
Yeah.
we can work together and we can,
Right.
help the patient. Like at the end of the day, it's the patient that needs help.
Right. 1 in 1 person has a pelvic floor.
Yep.
So 100% of the patients you see have a pelvic floor. Like,
I love that. I usually say everybody and everybody has a pelvic floor, and now I'm just going to say 1 in 1 people have a pelvic floor.
that
Straight to the
that's
point.
that's my quotable for this episode. And I think this could snowball out of control very quickly. But I think we as a profession have done such a good job of, again, delineating the different areas of physical therapy and defining the different areas of physical therapy. Like, they have now become niches that people won't won't step into, won't explore, or won't even like get involved in unless they're like super excited and passionate, and maybe even have some kind of experience with that. But that only, unfortunately, makes things harder on our patient, because again, if we're like, nope, I don't want
Yep.
anything to do with, oh, you have cancer, I don't want anything to do with cancer. Oh, you have pelvic floor issues, I don't want anything to do with that. When in fact, we are treating the whole body. Going back to your everybody
Yeah.
has a pelvic floor and may or may not have issues that need addressing. And it's not really fair for the patient to have to go to all of these different practitioners just to get some information, right? Now, I
Exactly.
know I am not going to fix your pelvic floor issue, but I can get you started with some really simple education. And I can, in turn, educate myself as the
Yeah.
physical therapist on what are some of the common issues that patients face when it comes to oncology and pelvic floor. What are some basic strategies I can get started with? So, Alex, what are some of the, let's kind of take a bird's eye view. What are some of the pelvic floor issues that patients face in oncology, whether related directly to the cancer diagnosis and treatment or just because they have a pelvic floor?
Yeah, absolutely. So we can kind of divide it up into a couple different buckets. So
Mm-hmm.
we've got bladder issues, bowel, pelvic organ prolapse, pelvic pain, and then sexual dysfunction. So those are kind of like our overarching buckets. And those can be experienced with or without a cancer diagnosis or treatment. But again,
Mm-hmm.
with certain treatments like, say, pelvic radiation, if somebody already has urinary urgency,
Mm-hmm.
now they have cystitis because of the radiation that's going to just exacerbate that even more.
Mm-hmm.
Um, so with the bladder, people can have urinary incontinence or leakage, and that's even just a drop. It doesn't mean that you're letting loose your whole bladder. Even a drop of unwanted urine in your underwear or your pad, that is incontinence.
Mm-hmm.
So incontinence, urinary retention, so difficulty emptying the bladder, painful bladder syndrome or cystitis, urgency, frequency, having to get up at nighttime. So those are all issues that can be experienced with the bladder. Bowel, people can have constipation or diarrhea. As we know, a lot of times people experience diarrhea with chemotherapy. They,
Mm-hmm.
with pain medications, they can have constipation. Pain with bowel movements, and that can be in the abdomen or at the pelvic floor at the rectum.
Mm-hmm.
With pelvic organ prolapse, and I don't have my pelvic model with me today, but I always usually have my little sidekick. But with pelvic organ prolapse, it's when one or more of the organs start to drop down into the vaginal walls. So the bladder drops down, the uterus or the rectum drops down. If you think about somebody who's had a hysterectomy as part of their cancer treatment, long term, that's going to increase the risk for developing a pelvic organ prolapse.
Okay.
Pelvic pain, so anything from genital pain, so scrotal pain, penile pain, vaginal pain, clitoral pain, rectal pain, coccyx pain, anything in the pelvic
Mm-hmm.
area.
Mm-hmm.
And again, you can have that independently or after a surgery, after radiation, right? And then finally, the sexual dysfunction. Again, you can, that's a whole other podcast. But I mean, with sexual dysfunction, there's so many things that can go into that. And
Yeah.
then on top of it, now with cancer, if you've had even a mastectomy, right? That changes your body image, that changes your sexual play. If that's a typical area that is part of your sexual play,
Mm-hmm.
and now you don't have sensation or it's painful to touch, that's going to cause a huge impact on somebody's sexual health. So,
Mm-hmm.
pelvic floor wise, again, you can have vaginal dryness or pain, or a lot of different things that could be happening. Erectile
Mm-hmm.
dysfunction.
Yeah. We've talked previously about how people can screen for these things in patients because, again, one of the worst disservices I think we can do for our patients is not asking the question.
Hmm.
So when you're crunched for time and your patients are filling out, it feels like endless sheets
Right.
of intake paperwork, what is a way that the therapist who is like, oh my God, I don't even know where to start asking these questions, what is a way that they can start asking these questions with their patients?
So I think an easy way would be to tie it into their treatment or kind of what they're coming in for symptom
Mm-hmm.
wise. So if they had chemotherapy as part of their treatment, you could say,
Mm-hmm.
as with chemotherapy, some people can experience some bowel just or GI distress or other pelvic floor issues. Are you okay that I ask you a couple questions? Simple as that.
Nice.
Or,
Nice.
is it okay that I ask you about any issues you've been having at the pelvic floor? That includes anything with your bladder, your bowel, and really like asking it in a kind way, but a confident way. Because if
Mm-hmm.
you're nervous and you're like, are you okay if I ask you this question? And you're like nervous and like, ugh, like they're gonna be nervous. Like they're not gonna want to open up. But if you're like, hey,
Mm-hmm.
like a lot of cancer survivors deal with pelvic floor issues. I just want to screen you real quick for if you're having any concerns down below,
Mm-hmm.
you know? So there's a lot of different ways to kind of approach it, but I find that tying it into either their treatment or like basically just not so you're coming out from left field like, hey, we're talking about your shoulder.
Yeah.
How's your sex life? Right? Like you need to have a little bit of a segue into it to make them understand why you're asking those questions.
Mm-hmm. Mm-hmm. Maybe don't have like shirt off MLD out of the blue and be like, how's sex?
Right,
Is it
exactly.
no
Exactly.
problem?
That doing
No
that might
problem.
prompt you to think like, oh, like this is painful. Maybe they're having some issue. Like, and that's good. But then at the end of the
Mm-hmm.
session, or maybe wait till the next session,
Yeah.
right? Because then if you ask something on their way out the door and then they leave like, oh my gosh, like why did she ask me that? Like, ooh. And
That
they
was
don't
kind of
have time to
weird.
explain it or go through it or get a referral or something like that. So that'd be good to ask more towards the beginning of a session, for example.
Mm-hmm. I'm really glad you bring up the beginning of the session aspect. This is something that you don't want to rush through. As a non-pelvic floor physical
Yep.
therapist, I think one of the worst things that I can do is to try and rush through that. Like as the patient is leaving, be like, "Hey, by the way,"
Right,
because
right.
again, you don't get to explain it. You don't get to really like answer any questions that they have and connect with them and make sure that you're like, can we have a really honest conversation right now? And
Yeah.
it's surprising. One of my favorite stories related to this is I once had a patient who was not a primary English was not her first language. And so she brought her daughter, who was fluent in both, to work with us. And so I was really nervous. The patient was a like 70 some odd year old woman who was being treated for some kind of pelvic cancer. I can't remember if it was vulvar or vaginal, but it was one of those. And she was having radiation in that area. And I was so nervous. I was like, oh my God, like, I don't know how this is going to go. Like, are we going to get an answer? Like, is she going to be like, whoa, too much, too much? And so I did. I framed it in, a lot of patients who are treated with radiation like this can experience some pelvic floor dysfunction, including difficulty with urination, difficulty with, defecating, and difficulty with sex. Is that something we can talk about? And to my surprise, the patient was like, yes, I would like to talk about that. And she told me how one of the things that was so important to her is that she wanted to get back to having sex with her husband. And I was like, which again, That is my own ignorance of like, wow, old people have sex. Yes, old people have sex. At
Like
least like,
80s, 90s.
come
I
on.
literally worked with people in their 70s, 80s, 90s that sexual dysfunction is what they're coming in for.
Yes. Like,
Never too
come
old,
on.
friends.
Never too old. So that
But
was a
that's
really
amazing. And it makes
educational
you
opportunity.
wonder, like, how many other providers didn't ask
Oh my
because
God.
they weren't comfortable with the daughter being there or with the interpreter being there, right? It makes you really wonder, like, I'm actually wondering now, like, how many people aren't getting screened for these things that are potentially taboo or embarrassing because there's an interpreter or another family member in the room if they're not, if English isn't their first language.
Hey, you should do a study on that.
I'm really interested. Like how many people this is already not being asked enough anyway.
Right. And I feel not in a malicious way, at least on the part of most professionals. I think that's an easy excuse not to ask
Absolutely. Yep.
because they have a concern that they're going to be uncomfortable when they're already uncomfortable, and it's an easy like, I'm just not going to ask it.
Yeah. And that just does a disservice to the patient.
Yeah.
The worst that happens is they get embarrassed. And if there is someone else in the room, I say, is it okay that I ask you some questions about bladder, bowel, or intimacy?
Mm-hmm.
And then they have, the option.
Right. But they have the option to
Exactly.
yes or no, right? But I think even asking that and they say no in that moment, they may reflect on it and
Yep.
say, actually, I do kind of have a problem. Or like,
Yep.
wow, that was really cool that she asked that question. I am going to talk to her next time,
Yeah.
for example.
Yep. And a lot of people do that. If they say no or they kind of minimize it that first time that I ask,
Mm-hmm.
then the next time they're like, kind of sheepishly, like, you remember last time and you kind of asked me about my sex life and like the whisper it.
Right.
I'm like, yeah, like is some you want to talk about something? You're like, actually, yeah. And it just opens the door, right? Like it's just
Yes.
empowering people to recognize that they can have a voice for these symptoms that are just not talked about a lot or not asked about a lot.
Yes. Oh my God. And man, that is like the coolest thing when the patient does open up to you because they know that you're a safe space, like you're creating a
Right.
safe space for that. Oh,
It's my favorite.
that is so cool.
It's my favorite. It's
Oh
like a cupcake, all the sprinkles, all the frosting. You take the bottom off, put it on top, and then you just
my God.
little cupcake sandwich. Like that's the best.
That's how I eat my cupcakes too.
This is why we're friends.
This is why we're friends. Oh my God.
I can you believe
Mm.
how many people have never heard of doing that?
It's a little more than I would like to
I
acknowledge
know.
because yes,
It's my favorite. But
probably about
that's
the
the
same
feeling when
amount of
somebody opens
people.
up.
I was going to say probably the same amount of people who don't know that they should screen their patients for pelvic floor dysfunction.
Exactly.
Cupcakes, pelvic floor dysfunction, same thing. Same thing.
Exactly.
Okay, so I'm listening right now and I'm thinking, I have this much information and knowledge and experience when it comes to pelvic floor. Like, I am very confident in my ability to screen patients for dysfunction. And I have some pretty good pelvic floor physical therapists in my area that I feel very comfortable referring to. I know that's not always the case in other areas, which is
Mhm.
part of the challenge, but I'm at a point where I know some stuff enough to be like, I can screen you and then refer you out. But that's where my knowledge stops, Alex.
Mhm.
And I find that that's a lot of where my listeners' knowledge stops of like, I can screen you. I know how to screen you, but I don't know what to do from there.
Right.
And you've come out with a brand new course that I'm so excited about that is designed to bridge that gap and to start those conversations, but also start providing that follow up for that patient. Can you tell me about your course?
Absolutely. So this is my first course that I came out with. I'm very excited about it. It's called Pelvic Health Foundations for the Oncology Rehab Provider. So it is a pretty comprehensive course. It's 5.5 hours. It's approved for CEUs in I think like 43 states. including
Nice.
Texas. Woo, go Texas.
Yes. God, we're so complicated. We're so complicated.
Really, yeah, I had to submit separately for that,
Mm-hmm.
as I'm sure you know.
Mm-hmm. Yep. Yep.
Um, but again, I just kept meeting people at like conferences who would come to my talks, or we would just network, and they would say like, "Oh, like I just refer people out," or "I just don't even know what to do with that," right? And so, yes, absolutely, like refer out, right? Like if that's not your specialty, absolutely. But could you also do more for the patient while they're with you? When we look at access to care and co-pays, and I mean the cost of and the time of having to get a new referral depending on what your direct access is, or
Mm-hmm.
I'm in a hospital system right now, we still require a referral. We work with a lot of
Yep.
insurances that only allow 6 visits per year, period, right? Like
Mm-hmm.
there's so many limitations. And when a lot of cancer survivors and people living with and beyond cancer have so much also financial toxicity,
Mm-hmm.
if we can just do 10 to 15 minutes of education or intervention, or incorporate different cues in our exercises to help the pelvic floor and their symptoms,
Mm-hmm.
like that would be huge,
Yep.
right? I mean,
Yep.
even from primary care providers or from a urogynecologist or a urologist that are referring to rehab, they're still at least giving the education to get them started until they can get in with us. Or maybe
Yes.
they aren't able to get in with us initially, for whatever reason, whether it be location. Like you said, there's a lot of places that still don't have a pelvic therapist,
Mm-hmm.
um,
Mm-hmm.
or a pelvic therapist that don't have that additional training or comfort working with with oncology population, which
Yeah.
is why I'm making a course for pelvic therapists coming out later this year.
Oncology Foundations for the Pelvic Floor Physical Therapist by Alex Hill, patent pending.
Basically. But again, like each specialty really needs to be able to bridge that gap. So that's
Mm-hmm.
essentially what the course is. So going through the pelvic anatomy, I do include some more lymphatics in this oncology one,
Eee.
compared to what I'll probably be doing for the pelvic floor one,
Mm-hmm.
just because more likely to have a CLT or treat lymphedema.
Yeah. Yeah.
The bulk of the course, so it's a 1.5 hour module, is talking about those buckets of conditions that I was talking about earlier. So the
Mm-hmm.
different types of urinary incontinence, and okay, what do you screen for? Like, what do you ask? Or if the patient says these things, that can clue you into what type of leakage it is.
Mm-hmm. Mm-hmm.
We'll go through the different types of cancer treatments, not in great detail like your course would go into, with the very in depth, like this is what radiation therapy is, this is what
Right.
chemotherapy is. It's more of an overview, but more
Mm-hmm.
specifically going into how do those impact the pelvic floor and pelvic health.
Yes.
And then looking at what your assessment can be. So again, you're not a pelvic therapist.
Mm-hmm.
I mean, I do want everybody to be a pelvic therapist, but if you
Right.
don't
Right.
want I don't want you to be one either, but you should be able to screen the pelvic floor just like you screen literally any other part of the body. So I go through
Mm-hmm.
external
Mm-hmm.
techniques that take a minute to do just to check, okay, are you doing a Kegel correctly? Do you have pain at the pelvic floor, like your patient or you mentioned earlier, because of your
Mm-hmm.
radiation therapy?
Mm-hmm.
Right? And then I have a short module on genital lymphedema, very short module. And then also one on basically how to provide the most empowering and inclusive care for your patients. So, like, how do you educate? Like, what do your educational materials look like? Are you using all the materials that are heterosexual, cisgender, white, thin model? Like,
Mm-hmm.
that's not what we look like,
Mm-hmm.
so how do you improve how you're educating and what you're educating on, to be able to provide that best type of care?
Mm-hmm.
So I'm really excited about it.
One of the things that we were talking about off air that you didn't mention here, but I want to bring back around, another really important reason why I think we need to be taking this course is in my area in Fort Worth, we have some great pelvic floor PTs, as I mentioned previously. but they also can have significant wait times.
Yep.
And our patients may not be able to completely stop their care with us and just wait for an opening to show up with their local pelvic floor physical therapist or whoever that provider is for them, right? And
Yep.
so we know, especially in this day and age in healthcare, like wait times are a very, very significant barrier for a lot of patients. And that may be like, I'll throw out another example. 2 springs ago, when I was studying for my board certification exam, I studied myself into trismus.
Oh no.
Woke up one morning, literally, it was night and day. Like I ate just fine the night
Oh
before,
my gosh.
woke up, and I go out to the kitchen and I pour myself some cereal, pour some milk, and I grab the spoon and I go to, and I hit my teeth with the spoon. I was like, I have never done that before. I could not open my mouth wide enough to fit a spoon of cereal in. And it was like, oh my God, I have a problem right now. And it hurt, obviously, like it didn't feel good.
Right.
And I had a very immediate problem of like, this is an issue right now. I didn't know that TMJ could be such an acute issue, but let me tell you, I know now. And
Yeah.
I needed
Wow.
help right then, right now. And our patients sometimes have issues like this where they need help right here, right now, and they can't wait 3, 6 weeks, multiple months
Yep.
to be able to see a therapist who knows anything about the pelvic floor. Like, we could very much be a starting point for them that then, when they're able to get connected and get an appointment with the pelvic floor physical therapist, then we can transition that care, right? We can
Yep.
work on other things, incorporate a little pelvic floor, and then get them connected with the more experienced provider who can really comprehensively help with those issues that they're experiencing. And this course, I think, is really going to help with that, of us being that kind of middle transitional, I think, provider in that
Yeah.
capacity.
I don't think I could have said that any better. That's exact, but I mean that's exactly it. I've been very lucky and fortunate that I've worked in larger hospital systems where we have both pelvic health and oncology therapists.
Mm-hmm.
But again, I've talked with other people, and I know a lot of therapists who they don't have as many, or it's such a long wait time to get
Yeah.
in with them, or they're limited with how many evals per 6 month period they can do. I mean, there's so many different
Yeah.
reasons why there could be limitations and limits to access to care,
Mm-hmm.
and how amazing that you can help them with this very personal, potentially debilitating thing that I can't tell you how many people I have that they don't even want to leave the house because they're nervous that they're going to leak,
Yeah.
and sometimes just reassuring them that, like, no, there is help available. Like, I have this great pelvic therapist. Here's what I can start you on now.
Mm-hmm.
Right? Like, that's really my goal for this course, like to empower onco PTs and OTs, PTAs, OTAs, right? To be able to confidently screen for, like you are now, it sounds like, these pelvic health issues. We go through cases, we go through like, how would you ask this
Mm-hmm.
patient about XYZ? And be able to actually implement it. And that was one of the things that I
Mm-hmm.
really wanted. Was, we were talking about this before, is like, we've taken courses, plenty of courses, where we leave and I feel like I need a week to digest it, to then like be able to actually implement it. Like, I want people to take this and be able to say, oh, I know how to check, their coccyx, so I can see if they're doing a pelvic floor contraction correctly. Like, oh,
Mm-hmm.
I know what type of fiber I can recommend for them. Like, just these very simple things that, like, I want you, when you're done with this course, to be able to implement that right then.
Mm-hmm. And leading very much like continuing with that, we talked off air about that exact thing of like, we've been to continuing education courses where you walk out and you're like, I'm exhausted because I've been in a fluorescent lit room for 8 to
Oh,
5
yes.
Saturday, Sunday, right? And then I have to go to work on Monday, and
Yeah.
then I'm trying to implement what I've learned into practice, and then I come up with a not textbook patient, which is like all of them,
Yeah.
to where it doesn't exactly translate. And
Yeah.
so I have had trouble where I'm like, well, I learned this course and I paid this money, and now I don't feel like I can actually use it because I don't have the support after the course. But your course is different in that capacity. How, Alex?
So we have a Facebook group that people are able to join once they take the course, they pass the course, and then they can join it. So it's just for the clinicians who have taken these courses. So you already know that you are with like-minded individuals, so
Mhm.
onco or pelvic rehab therapists that want to learn more and collaborate together. So that's something that I felt was very important to, especially for
Agreed.
people that don't have someone else in the clinic or don't have someone mentoring them or don't have, just a collaboration with somebody else. Like, hey, we're here. You can collaborate
Hmm.
with us in this group.
That's amazing. How can people sign up? Like, where do we go? Take my money already.
OncoPT. Yeah, so it just launched on 2 days ago. What's today? Yeah, 2 days ago. Like this week is already
Yee.
crazy. Which is exciting. We've had about 5 people sign up, which just is super duper exciting. That was my goal for this first week. So thank you to the 5 people
Amazing.
who have signed up for this course this week. You have made my dreams come true. But people can sign up at oncopelvicpt.com. I also have links on all my social media with Twitter and Facebook and
Mhm.
Instagram and all the things.
Yay. Okay, so you can find that at, again, oncopelvicpt.com. Alex has a ton of great resources there, obviously, and then her courses there available. And just to recap what she said previously, covered for CEUs in 43 states, which is
43.
so many. So many, Alex. So congratulations. I know the work that it goes into getting things CEU approved. So
Yeah,
way to
that
go,
was
my
fun.
friend.
And I am trying to get it approved with AOTA. That's a whole
Nice.
other process, because OTs and OTAs. I mean, they're in the oncology obviously space, but also growing number in the pelvic health space
Right.
as well. So again, having a course that's welcoming for all rehab therapists was important to me too. So
Hmm.
currently working on the AOTA, but it is a very long process to do that. So hopefully in the near future we'll be getting that done too.
Yeah, girl, same. They don't make it easy, that's for sure.
No, or cheap.
Yeah, or cheap. Whew. Well, first of all, I'm really, really excited for your course because it's been long overdue. Like, this is something that Kelly, who I have created, so Kelly Sturm, who I've
Hey,
created courses
Kelly.
with previously, we have talked about of like, we're doing really good things. Kelly's a pelvic floor PT, and we've identified like, there are some really cool organizations out there who are doing really comprehensive pelvic floor education, but there's not that connection of pelvic and oncology. And I'm so excited that you're the one who is taking this flag and just like charging forward with it because it's long overdue. It is so needed. And again, one of the things that really resonates with me is like, this is not a course that's going to leave you hanging after you finish it. You are going to finish with the modules, and they be able to come back and conference with people who have gone through that course, who are implementing that same information in their own practice and saying, this is what's working for me. This is how I've had to modify it. Have you considered this kind of deal? And that is what is super, super needed in our
Hmm.
world right now, in this cancer rehab world of ours.
Yeah, absolutely. There's, I'm on different Facebook groups with oncology rehab, and
Yeah.
I'll see questions about like, I have a patient with an ostomy bag, like what type of core exercises can I safely do? Like like the pelvic health therapists are the ones that are typically
Yep.
answering those.
Yep.
So and I think
Absolutely.
there's a lot of things that people just don't realize that like you can address this. Like I
Mm-hmm.
explicitly say at the beginning of my course, like after taking this course, you are not a pelvic health therapist
Right.
by any means. Like this is an adjunct to your oncology skill set, right? Like you are blossoming your skill set, but that does not make you a pelvic therapist, but you have the skills to be able to confidently start getting people better when they need it.
Mm-hmm. One last thing I'll end with is if you just cannot get enough of Alex, which if you're like me, I cannot.
Well, I can't get enough of you either, so.
Oh my God. Well, buckle up, friend, because Alex is also going to be one of our fabulous presenters at our first ever Cancer Rehab Community Conference happening this November 11th. Again, if you can't get enough of her, like me, this is going to be the perfect opportunity to get to hear her speak and share all of her amazing wisdom, in addition to this incredible course that she's created that is going to help so many. And I'm really, really excited to take it myself because, like I said, I can screen enough to be dangerous and then I just kind of leave my patients hanging. And I don't want to do that anymore. So, Alex, thank you so much. Where can people follow you on social media?
OncoPelvic PT, Facebook, Instagram, Twitter, and then I started a YouTube channel in January. So I'm now on diving into the long length form.
She's also had a thriving TikTok channel for a hot minute too. So don't forget about that. I see you all the time on TikTok. It's perfect.
It's so hard with well, we can talk about this off air, but they have now increased the character limit, which is nice on TikTok, but it's still just need a lot of the stuff that we do. I feel like you just need more content behind it or information behind it. But
yeah.
Anyway, but all the social media.
Perfect. Well, Alex, thank you again so much. Of course, listeners, I will be linking to the course in the episode show notes to make sure you have all the information you need to get there and sign up. Like she said, approved for CEUs in 43 states. So it's a good chance that your state is going to be on there. So, yeah. Alex, thank you so much. Again.
I appreciate it. And thank you for all you do. See, I'm super stoked for the conference this fall. Like, this is so needed. So thank you for taking the flag and leading the charge in this.
Thank you.
I know it's going to be awesome.
We're just taking our flags and running together. Like,
I'm bringing a flag to CSM next year.
Dude, I don't think CSM is ready for us.
I don't think so either.